Hello, I'm Dr. Yusafit. Welcome to my YouTube channel. Today we will proceed to exit example 6. So question number 1. A 56 years old man with type 2 diabetes mellitus of 15 years duration is being treated with metformin, lampride, and stagliptin. The patient also has hypertension, hyperlipidemia, and coronary artery disease. His current hemoglobin A1C level is 7.5%. Switching to insulin therapy to attain better glycemic control is discussed with the patient, and intensive glycemic control is with a goal hemoglobin A1C of less than 6.5% is most likely to reduce the risk of which of the following complication: A, stroke; B, hypoglycemia; C, myocardial infarction; and D, retinopathy. So this question is asking you about if we reduce hemoglobin A1C below 6.5% in patients with diabetes mellitus, which of the following complication do we reduce? So let's discuss. So glycemic control in type 2 DM patient can be evaluated using 3 parameters: hemoglobin A1C, fasting blood glucose level, and postprandial glucose. So for the what is hemoglobin A1C, by the way? What is it? What is hemoglobin A1C or glycosylated hemoglobin? So this reflects your average sugar. Hemoglobin A1C reflects average blood sugar level for in the past 2 to 3 months in patients with diabetes. 2 to 3 months, the past. So this is very important to sum up the average glucose level in 3 months, in the past 2 to 3 months. So specifically, this hemoglobin A1C tests what percentage of hemoglobin, hemoglobin protein in your blood are coated with sugar. So, uh, by the way, most of the monosaccharide like glucose, as well as fructose and galactose, spontaneously or non-enzymatically bond with hemoglobin. They bond with hemoglobin. The reason we choose we choose the bond between glucose and glucose and uh, hemoglobin instead of fructose and hemoglobin, galactose and hemoglobin is that this glucose is less likely to do the bond or the linkage. So is if it bounds in excess, it tells us hemoglobin. I mean, this sugar level is high. So mm, that we choose glucose for that reason. They do the bond less likely. So if you found the excess amount of glucose to hemoglobin linkage in the blood, so that may indicate of diabetes in high concentration. Even if, for example, if hemoglobin A1C, if hemoglobin A1C is greater than 6.5%, I mean 6.4%, or if it is greater than or equal to 6 point greater than or equal to 6.5%, this is diagnostic for diabetes mellitus. So we use hemoglobin A1C level not only for glycemic control, not only for that, we can also diagnose glucose for diagnostic purpose as well. So this is very important. So the process of this glucose attachment to hemoglobin is called uh, glycosylation. Glycosylation. So, and also the required in diabetic person, the required amount, especially in those elderly patients, I mean in youngster and youngster patients, it is less than 6.5. Whenever the patient come for follow-up, and when you do the hemoglobin A1C is, and if it is less than 6.5% in those young patients, and so it is we can say this is controlled range. So the other is fasting blood sugar level. So fasting blood sugar means the patient is in fast for at least 8 hours. He doesn't or she doesn't take any meal before 8 hours, and then you will measure, and the normal range is for the fasting level, the normal range is below 100. I mean, below 100. Yeah, below 100 milligram per deciliter. Below 100 milligram per deciliter. So if it is 100 and if it is 100 and up to 124, so this is pre-diabetes range in 100, between 100 and including 100 and up to 124, including 124 milligram per deciliter. This is pre-diabetes level with fasting, pre-diabetes. But if it is greater than or equal to, including 125 milligram per deciliter, this is diagnostic of diabetes mellitus. So we can use fasting blood sugar level for diagnosis as well as to study the glycemic control. So when we come to the glycemic control, we need to have less than 130 milligram. 130 milligram. So for diabetes patient, less than 130 milligram per deciliter of fasting glucose level is the range we need. So this is the controlled glycemic range when we do the fasting. And don't forget that the glucose level should not be less than 70 milligram per deciliter, and that is hypoglycemia, and that is more serious than hyperglycemia that will result in devastating, and even may lose our patient. So this is the control range for the diabetic patient. The other is the postprandial glucose level. Postprandial glucose level. This is when up to 4 hours of after eating, you can use postprandial, or after 4 hours after eating. So this is called postprandial. That means it is we measure up to 4 hours after eating. So the normal is less than 180 milligram per deciliter. 180 milligram per deciliter. 180 milligram per deciliter. And this is a control. I mean, this is what we need. This is a controlled range, especially in the diabetic patient. So when we go back to our question, there is robust evidence to suggest that strict glycemic control reduce diabetic microvascular complication like retinopathy, nephropathy, and neuropathy. Those are the micro complication of diabetes mellitus in both primary and secondary prevention setting. So while unequivocal evidence that intensive glycemic control reduces the risk of death due to macrovascular disease is lacking, so meta-analytic data in controlled clinical trial data suggests there may still be clinically significant lowering of risk of microvascular in the point of strict glycemic control. So this study tell us that by reducing the strict glycemic control, we can reduce the microvascular complication. But there is not enough evidence that only by tight or strict glycemic control reduce microvascular disease. That means we need another factors. Instead, in addition to this strict glycemic control to reduce this microvascular complication of diabetes. That means microvascular complication is like peripheral artery disease, cardiovascular disease, as well as cerebrovascular accidents. So cardiovascular disease, for example, this is cardiovascular disease, and this is macrovascular complication. Macro, large blood vessels. So macrovascular, one of the macrovascular complication of diabetes mellitus is a collision of several factors, not only the strict glycemic control or a failure of this strict glycemic control. So it is a collision of several factor beside hyperglycemia, such as hypertension, dyslipidemia, diffuse endothelial dysfunction, hypercoagulability, and inflammation. So, for this microvascular complication, we need those additional factors uh, and, uh, instead of only hyperglycemia to reduce. So the answer is one of the microvascular complications. So when we go to the microvascular complication, only strict glycemic control is enough to reduce those micro small vessels complication of diabetes mellitus. So the answer is, so a stroke, which is cerebrovascular accident, is one of the macrovascular complication. So we have another factor instead of hyperglycemia alone. So the other is myocardial infarction. Sorry, myocardial infarction. It's also the other cardiovascular complication. It is also is on the macrovascular complication. So it need another factor as well. So hypoglycemia is not associated with that. So this is the answer. D is the answer. Retinopathy is the microvascular complication. And so it is enough only that glycemic or strict glycemic control is enough to reduce the risk of this retinopathy. So for the other, especially for the stroke and myocardial infarction, we need another factors. So the second question is, a 55 years old Caucasian male present to the office for routine checkup. He has no present complaint. His past medical history is significant for long history of hypertension. He doesn't smoke or consume alcohol. His current medication are enalapril and hydrochlorothiazide or HCT. His blood pressure is 140 by 90 millimeter mercury, and heart rate is 18 beats per minute. Physical examination reveal a moderately overweight man, BMI is greater than 27 kilogram per meter square, with a waist circumference of 102 centimeters. The laboratory fasting blood sugar studies show 112 milligram per deciliter, which of the following is most important pathogenic factor for this patient's condition? Impaired secretion of insulin, B, low absolute value of insulin, and C, insulin resistant, and D is sympathetic hyperactivity. So please read the question attentively and then answer this question or choose your answer. So let's discuss. What does this patient have? So the patient is non-hypertensive and his current blood pressure is 140 by 90. The other is this patient had fasting blood sugar level is 112 milligram per deciliter, and other very important is the waist circumference is large, so it is 102 centimeter. So what do you think when we say if we're hypertensive, that is 140 by 90, or he has history of hypertension and waist circumference of 102 centimeter and elevated blood sugar level? That means in the pre-diabetic range, it is in between 100 and 125 milligram per deciliter. What syndrome does you have in your mind if we're turning those three parameters. It is metabolic syndrome. Metabolic syndrome. This patient has metabolic syndrome. Metabolic syndrome. We will discuss in table next slide. So this patient have metabolic syndrome, and most importantly, this patient have overweight, in the range of overweight. So overweight brings, in short, this question is asking you, overweight brings A, impaired secretion of insulin, B, low absolute value of insulin, and C, insulin resistance, D, sympathetic hyperactivity. So the answer is, if you say insulin resistance, you are correct. So obesity, this patient must have the range of overweight, obesity, as well as metabolic syndrome, especially metabolic syndrome. If the patient have metabolic syndrome, is related with insulin resistant and type 2 DM. So it is type 2 this patient. So metabolic syndrome is related with risk of type 2 DM. Or most of patients of metabolic syndrome in the future will develop type 2 DM, have a risk of to develop DM as well as a stroke. So this patient have insulin resistance, overweight, and overweight can result or have a risk factor for the insulin resistance in type 2 DM. Let's discuss. Obesity is a triggering factor for diabetes with insulin resistance, not absolute deficiency of insulin or low insulin level. So in individuals who are obese, higher amount of non-esterified fatty acids, glycerol, hormones, and pro-inflammatory cytokines that could precipitate in development of insulin resistance are released by the adipose tissue. And this patient with this high waist circumference, or the patient may have further after that the patient may have central obesity. So with this overweight, the patient had this excess adipose tissue, which release those all factors, and which result in the insulin resistant in type 2 DM. So this is metabolic syndrome. So elevated waist circumference for men, it is greater than or equal to 102 centimeter. In our patient, it is 102 centimeter. So, and it is male. And if it is greater than or equal to 88 centimeter in woman, and also the other parameter is elevated triglycerides level, if it is greater than or equal to 150 milligram per deciliter, or on drug for elevated triglyceride level. That means the patient may have, for example, 100 milligram per deciliter of triglyceride, but if the patient is in treatment for triglyceride, we count as this is one parameter. So the other is reduce HDL-C level. For men, it is less than 40 milligram per deciliter. For women, it is less than 15 milligram per deciliter. Or in treatment for the reduced HDL level. So the patient may have even greater than these amounts, but if he is in the treatment for reduced HDL level, the patient have one parameter for metabolic syndrome. The other is elevated blood pressure, that is 130 millimeter mercury systolic and 185 milligram for diastolic, or the patient have history of antihypertensive and is on treatment for antihypertensive treatment. So the other is elevated fasting glucose. If it is greater than or equal to 100 milligram per deciliter on drug treatment or on drug treatment for elevated glucose level, or the patient have history of diabetes mellitus. So in our question, the above patient have one is elevated fasting blood glucose level, that is 112 milligram per deciliter, and also elevated blood sugar level 140 by 90 milligram per millimeter mercury, or is the patient is on already now on antihypertensive and also on treatment for enalapril and HCT, and also have the waist circumference of 102 centimeters. So this patient have definitely metabolic syndrome. So if any of 3 out of 5 consecutive diagnosed metabolic syndrome, and our patient have 3 parameter and is in metabolic syndrome. So in short, metabolic syndrome means is a cluster of conditions that occur together, increasing your risk of heart disease or cardiovascular disease, and also stroke as well as type 2 DM. So the importance of this diagnosing metabolic syndrome in a patient is to assess the risk of a patient to have heart disease, a stroke, and also type 2 DM, and then we will act accordingly, or we will manage accordingly. So definitely this patient have insulin resistance. So one thing I should have to talk about is this about HDL, and the HDL is called good cholesterol. Good cholesterol. Good cholesterol. That is why we need it in excess or in increased amount. So if it is low, if good thing is low, that may result in bad situation. So we need increment of HDL level to reduce cardiovascular disease. So HDL, normally this HDL is produced in liver as well as in intestine. So the function of this HDL, the function of this HDL is that it transports cholesterol from the tissue, peripheral tissue. It transports cholesterol from peripheral tissue to the liver. So this it clean up the function. The function is cleaning the cleaning those cholesterol from the tissue to the liver and then this liver will excrete those cholesterols. So that is why we said good cholesterol. For example, if you take LDL, which we call it the bad cholesterol, its function is uh, so it brings cholesterol from the liver into the peripheral. We eat cholesterol, and by the way, when we ingest cholesterol, it is high yield of very low, not LDL, is very low density lipoprotein, and metabolism of those very low and intermediate density lipoprotein. Their further metabolism will result in the LDL, which is a bad cholesterol, and so it brings us in the tissue deposition, of cholesterol. And as we discussed, HDL brings from the tissue to the liver to be cleaned up, but LDL do its function. It brings to the tissue. It results in deposition of cholesterol in the tissue. That is why we need decreased level of LDL level when we assess for the cardiovascular risk of a patient. Also, this LDL is a bad cholesterol, and because it is a key ingredient in the development of an atherosclerotic plaque. So it is increased amount of this LDL will result in atherosclerotic plaque and will result in MI or other cardiovascular accidents. or the patient may have risk for that. So the third question is, a 30 years old female patient presented with sudden onset of very severe, very severe headache and with nausea and vomiting. She had slight neck pain and stiffness and had mild mental status changes, had mild mental status changes. So there is no weakness. There is no weakness of extremity. What is the likely diagnosis? A, pyogenic meningitis. B, ischemic stroke. C, subarachnoid hemorrhage. D, brain tumor. So please pause the video and answer your question. So let's discuss. This patient, this patient had, this patient had fever. I mean, not have fever, and also this patient uh, for 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 the question A, if you choose pyogenic meningitis, that is called bacterial meningitis. Pyogenic means pus-forming microorganism. So uh, it is bacteria. It means it is bacterial meningitis. So to diagnose bacterial meningitis, we need fever. Fever. So it is pyogenic, and we need fever. So this patient doesn't have fever. So the diagnosis for pyogenic meningitis is not correct. If you go for bacterial meningitis, we need in addition to those histories or those symptoms, we need fever, especially high-grade fever. So the patient that doesn't have fever, and we rule out pyogenic meningitis by that. B, ischemic stroke. In addition to those symptoms, we need what what do you need for ischemic stroke? It is the patient may develop weakness, especially in unilateral stroke. If it's not bilateral stroke, the patient may have one-sided body weakness. For example, the patient may have left-sided or right-sided body weakness, which you call it left hemiparesis or right hemiparesis. So the patient, there is no weakness for this patient in extremity. There is no weakness for extremity, and this would rule out ischemic stroke. So the third is subarachnoid hemorrhage. So this is the answer. This is the answer. So when we come to the D, brain tumor, So for brain tumor, especially the when if it is not, so brain tumor is one of the intracranial space occupying lesion. So the patient may have weakness in extremity as well as body weakness. And also, the type of headache for this brain tumor is deep dilating and disturbing, like it disturbs sleep. And with in addition to the headache, uh, or this headache will worsen upon coughing, lifting objects, and bending is typical of this, especially for the posterior for the brain tumor. So the correct answer is subarachnoid hemorrhage, especially for the subarachnoid hemorrhage. The patient will come as telling you this is the worst headache of my life. This is the worst headache of my life. It's a very, very severe headache. And the patient even tell us, this is the worst headache of my life. And sometimes it's characterized, the headache is characterized as thunderclap type headache. So this is subarachnoid hemorrhage. Let us discuss about subarachnoid hemorrhage. I'm sorry. So this refers to bleeding into subarachnoid space, while subarachnoid hemorrhage is often caused by trauma. 5 up to 10% of are non-traumatic or spontaneous, in which case they are often due to aneurysm, or involving the circle of Willis. So aneurysmal subarachnoid, if it is especially if it is non-traumatic, we go the most common causes aneurysmal. So let's see where is subarachnoid space. So this is the skull. from the exterior to inside or from the outside to in. When we come to this is the skull. So this is the dry matter. So the meninges is the covering or the lining of the brain. So next to skull there is dry matter, and then there is arachnoid, and then interior to the brain, interior to the in the interior structure there is pia mater, or the lining which is very near to the brain. This is brain parenchyma, is pia mater. So from outside to inside, we there is dura, arachnoid, and pia mater. So there is a blood vessels inside. There is a blood vessels next to arachnoid. That means in the subarachnoid space. So subarachnoid species in between arachnoid and the pia mater. Between the arachnoid and pia mater. This is subarachnoid space, and the bleeding is in this space. It is between arachnoid and pia mater, and this is the aneurysm. This is the middle cerebral artery which passes in the subarachnoid space. So typically this non-traumatic subarachnoid space manifests with sudden severe headache, which may accompanied by nausea, vomiting, and sign of meningismus. Sign of meningismus means it is neck stiffness, or neck rigidity, and or acute loss of consciousness. And also, the patient may have positive meningeal signs. Those three positive meningeal signs, that means neck rigidity, Bruniski sign, and Kernig sign. You should read that. Best initial tests for patient with subarachnoid hemorrhage is brain CT scan. Whenever you found or you suspect a patient with subarachnoid hemorrhage, the best initial test is to send the patient for CT scan through the blood subarachnoid hemorrhage. So the answer is the subarachnoid hemorrhage. So the same patient, the same above patient, and you send the CT scan for that patient and was reported to be normal. It's negative. What will be your next step? As we discussed before, for this patient, the best initial test for suspicion of or patient with subarachnoid hemorrhage is to send for CT scan. What if it comes negative? And what will be your next step? A, LP or lumbar puncture, B, MRI, C, angiography, D, ECG. So please answer this. It's a bad patient and you send CT scan and it comes negative. So what will be your next step in your management? You go for LP. You go for LP. Let's discuss. If there is highest index of suspicions for subarachnoid hemorrhage, and a negative CT hit doesn't rule out or doesn't exclude diagnosis. So second line tests are necessary, and that second line test is LP or lumbar puncture. So indication, history, and examination that is concerning for subarachnoid hemorrhage, but negative CT hit. So what does you see in LP? Opening pressure for subarachnoid, it may be normal or maybe it's slightly elevated, and also CSF color. In early findings, it may be pink to red, and late finding, especially 4 to 6 hours, after 4 to 6 hours of subarachnoid hemorrhage, you may find xanthochromia, and this is the presence of bilirubin in the CSF secondary to breakdown of red blood cells and resulting in yellow discoloration, and this is called xanthochromia, and this is pathognomic for the is very pathognomic for the subarachnoid hemorrhage. Xanthochromia is pathognomic for subarachnoid hemorrhage. So you will, by the way, you will do LP in space between L3 and L4. So the other is the cell count, red blood cells elevated, non-specific, no specific threshold. WBC maybe mildly elevated, and glucose normal. The glucose of this, when you send for analysis, LP, you draw LP and you send for lab, the glucose is commonly normal for subarachnoid hemorrhoid. And if it is, for example, a pyogenic meningitis, it is low. The glucose will be definitely low. So the protein is elevated. So the management of traumatic and non-traumatic subarachnoid consists mostly neuroprotective measures and example controlling of blood pressure to prevent secondary brain injury, and also to prevent the rebleeding. To prevent this rebleeding, you need neuroprotective measures, especially the blood pressure. In aneurysmal subarachnoid hemorrhage, microsurgical clipping and endovascular coiling of the aneurysm is indicated to prevent fatal rebleeding. So whenever you found this subarachnoid, a patient with subarachnoid hemorrhage, you go for, especially you go for ABCDE survey and manage those airway. If the patient's GCS is dropping, like if it is less than 8, you may have the indication for intubation. So don't forget ABCDE survey. So thank you. We will proceed another discussion next time. So this is your Academy YouTube channel. Thank you very much, and please subscribe and follow and like if it is very important. Like, and thank you.